need specialist care. So we also know that 95% of children globally have no or limited or no access to palliative care. So how does ICPCN work to meet this substantial need? Well, to sum it all up, we use the acronym CARES. We work in the areas of communication, advocacy, research, education, and strategic development. So I'd like to point you to the ICPCN website for more information about the organization, and to please have a look at our most recent impact report by downloading this QR code. So, thinking about children living with life-limiting and life-threatening conditions, and how can we optimize care and support provided to these children and their families. And bearing in mind that in children's palliative care, we see children across a range of developmental ages and stages, from neonates right to young adults. The WHO definition of children's palliative care talks about the active total care of the child's body and mind and spirit, and that also involves giving support to the family, emphasizing the holistic nature of care. Palliative care should begin when the illness is diagnosed and continue regardless of whether or not a child receives treatment directed at the disease, so across the disease trajectory. We want healthcare providers must evaluate and alleviate a child's physical, psychological, and social distress, once more speaking to the holistic assessment. And palliative care is no one-person job. Effective palliative care requires a broad multidisciplinary approach that includes the family and makes use of available community resources. And it can be implemented even if resources are limited. So children's palliative care requires collaboration. We also know that it can be provided in tertiary care facilities, in community health centers, and in children's homes, so across various settings. In children's palliative care, we see a wide range of life-limiting and life-threatening conditions affecting the children and young people, which may be categorized broadly into 4 groups, as outlined by the UK charity Together for Short Lives. And all these present with various trajectories. So a child with leukemia or with a brain injury, the purple line on top, falls into Act Class 1, where there's a chance of cure. Treatment might even be aggressive, and this child might even require ICU admissions. Up to a point when treatment fails, that child will drop into an Act Class 3. Act Class 3 is a child with cystic fibrosis or HIV, where we know that the condition where premature death is inevitable. There's a chance of a reasonable quality of life. Treatment is usually aggressive as long as the quality of life is reasonable. And in an Act Class 3, this is a progressive condition. So inborn errors of metabolism, trisomies 13 and 18, there's essentially no known cure. Available treatments may be experimental, and the focus is usually exclusively palliative. In the last Act, Act Class 4, this is when there are non-progressive conditions but life-limiting. The focus is on rehab and maximizing potential, thereby improving quality of life. So a child with cerebral palsy will fall into this category. But these Act categorization help us to make decisions on how active disease-focused treatment should be, and they are always dependent on resources. For example, a child with renal failure, if the child is in a setting and is able to access a renal transplant, that child will be in Act Class 1. But renal transplant may not be accessible, but dialysis might be. We might put that child into an Act Class 2. Where there is no treatment, that child will fall into Act Class 3. So just to look at the varied conditions and what the disease trajectories might look like. The WHO Guide on Integrating Palliative Care and Symptom Relief. This guide draws attention to the Pediatric Palliative Care Essential Package, and this provides for minimum palliative care and symptom relief that should be accessible by any child in any setting. This guide is based on the essential package of palliative care from the Lancet Commission that Helena's talked about, and has been adapted for children based on expert opinion. And the provision of the essential package can help prevent and relieve suffering, physical, psychological, social, and spiritual. And the package consists of a set of effective, inexpensive, off-patent, and widely available medicines. It is simple and inexpensive equipment, talks about basic social support, which is essential to promote dignity, and human resources need to apply the package appropriately, effectively, and safely, and accompany children and their families throughout the course of their illness. The access to medicines in pediatric palliative care, as outlined in the WHO Essential Medicines List for children, must include pediatric formulations. You cannot use adult formulations in children. And the United Nations Convention on the Rights of the Child, Article 24, further emphasizes that states have an obligation to make all essential medicines on the WHO model list of essential medicines, including the list for children, in pediatric formulations where possible. And this needs to be available, accessible, and affordable. So strengthening universal health coverage improves quality of life and patient outcomes. We know that pediatric palliative care may improve adherence to treatment, including cancer treatment, and that pediatric palliative care can improve comfort, but also strengthen the ability of healthcare systems to effectively treat life-threatening conditions. Helene has spoken about the lowering the health costs by adopting a universal health coverage approach, and pediatric palliative care is the right of any child diagnosed with life-limiting or life-threatening illness. ICPCN is committed to advocate for palliative care to be included in universal health coverage for children by skilled healthcare workers. So a reminder, we've seen this before, is that universal health coverage means that all individuals and communities receive the health service they need without suffering financial hardship. It includes the full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and of course, palliative care across the life course. So therefore, if there is no children's palliative care, there is no universal health coverage. And collaboration is key. It is important that we all work together to advocate for and achieve universal health coverage. One last thing, this year will mark the 10th anniversary of ICPCN's Hats On for Children's Palliative Care campaign. So please diarize the second Friday in October and look out for more information on social media. Thank you.
Thank you very much, Alex. Well done. So Howard, I hope we have some questions. We have 15 minutes left to discuss.
Yeah. So we have 2 questions and 2 comments. Maybe I'll just start with the questions so they can be addressed first. The first question is from, please pardon me if I don't say the name right, Tilo Govenda. Please comment on the palliative care support for patients with chronic infectious diseases. So he needs some clarification on that.
Well, I might ask Helena to respond to that, but before I do, I should note that a number of chronic infectious diseases are included in the 20 conditions that were identified by Lancet Commission as needing palliative care. That included, of course, HIV, which has long been, an area where we need palliative care. We recently published in Lancet HIV, and that's an open access article, an article with staff from WHO on the importance of palliative care for HIV, since we have had antiretrovirals, thank God, and thank goodness we have had a considerable reduction in mortality from HIV. But what we're seeing is an increase in non-communicable disease incidence for people living with HIV, and a shortening of lifespans because of various conditions, chronic conditions like HIV-associated cancers, heart failure, and other diseases of inflammatory reactions. TB is actually a bigger issue right now than HIV because of the mortality from TB approaching 1.5 million, whereas HIV is now quite a bit less than 1 million deaths per year. There are other conditions, meningitis, where infectious disease is particularly high symptom burden, and there's a high risk of mortality. We should have palliative care available for those infectious diseases. Other tropical infectious diseases and such that are essentially with proper care treatable haven't generally been included. Helena, do you have any other comment on this?
Yeah, I mean, I think I'd obviously support your remarks about HIV and TB being a particular problem at the moment that we're having to address, and the need for palliative care for people with multi-drug resistant TB in particular. But I think there are chronic infectious diseases where palliative care should be available and perhaps isn't available currently because they're not considered to be a part of the kind of palliative care remit. And I think one of the things which we're striving to do as part of our advocacy for palliative care is to really ensure that all individuals who are in need of palliative care, whatever their diagnosis, receive it, and not have preconceptions about what palliative care is needed for. So that where there are chronic infectious diseases which are going on for years, or where you've got sequelae of infectious diseases that would benefit from palliative care, there's the same need for palliative care as there is for non-communicable diseases. But I think it's a less well-addressed area at the moment.
Thank you. Thank you very much, Helena. Howard?
Yes, so the next one is a comment followed by a question, and I'll read. The need for integrated palliative care is obvious when compared to other healthcare services. However, in countries with legal euthanasia, I suspect that many policymakers are looking to the financial savings of people being offered euthanasia. The public, anecdotally, will not go through what they have seen their parents and grandparents go through. Over 80% of Canadians who ask are offered euthanasia and are also receiving palliative care. Each earlier death saves money. How do we combat the groundswell of acceptance of euthanasia and the underlying cost saving that policymakers don't speak about openly, but which must influence their policy development of palliative care?
Well, I'll start off the response to that, which is, first of all, that the international organizations have all taken a stand that euthanasia, assisted dying are not part of palliative care practice. So we are, in effect, the moderates in this sort of argument, because we have a policy of doing, I mean, from an ethical standpoint, of not doing harm. We also believe in autonomy and agency, and that people have rights to make decisions about all their healthcare. So our position is that we should have palliative care fully available to populations before public policy actions like legalization of assisted dying. But it is going to impact all of us, because I mean, and this person is, I believe, from Canada, Harry. And they're actually struggling with the situation, because it's the Supreme Court of Canada had made legalization of assisted dying very widely available before it actually before the country has done a good job of making palliative care available throughout Canada. These are difficult issues. We have to work with our patients and walk with them as they make some of these decisions. The majority of people who opt for or request assisted dying don't actually follow through, according to the research. This is another problem. There's very limited research on actually the impact of this on families post-death. And there's been a concern raised for a long time that people could be potentially pressured by family to die prematurely because of financial reasons. And governments, as Harry has pointed out, have perhaps an incentive to do this, though I don't think that's their overt incentive objective in legalization. But let's hear what others have to say about this, Alex or Elena.
Alex, do you want to comment, or shall I comment? I mean, I think go on, Alex.
No, I just wanted to reiterate Stephen's position. I mean, you know, in terms of the SPCN's position about euthanasia and palliative care, I don't really have much to add to the conversation. Yeah, and it you know, we've had a lot of discussion around whether we should, even at palliative care conferences, include focus on palliative on euthanasia. You know, does it detract from the work of palliative care? I think it's a very necessary discussion to have. But I don't. It's, you know, I think that palliative care, there's a lack of understanding in many settings, certainly where I come from, of what palliative care is.
Yes.
And I think the focus on educating and advocating for palliative care services, both for adults and children, needs to happen. More of that needs to happen.
Yeah, I mean, I agree. I would share, you know, reiterate Stephen's comments. And I think one of the issues, it's a very interesting question and very topical. I think one of the issues is that if people receive adequate palliative care and are willing to receive palliative care, both out the misconceptions that are sometimes associated with it, which I think is the educational aspect that you were talking about, Alex, that if people understand what palliative care is and you can provide them with a good quality of life in spite of the fact that they've got a life-limiting illness, then maybe some of them wouldn't choose euthanasia when they otherwise choose euthanasia. I mean, there is very poor research, so this is me speculating and expressing an opinion, but I think that's one of the aspects, you know, potential aspects, is that if we can provide good quality, widely available palliative care, then we can still allow people to have autonomy and to walk in their own shoes, but be able to do so with adequate control of symptoms and good quality of life, right up until the end of their lives.
Great, Helena. I agree totally on that. I think we really need to, for our patients who are seeking assisted dying, we always, you know, spend time to try to really get underneath and understand where their pain is, where their suffering is, that maybe drive for palliative care, and then address those issues when they can be addressed. You know, there also is research that shows from Oregon that personality characteristics are a big factor in the people who actually follow through with euthanasia, and the need for control being a particularly strong motivation. But enough said about that. I think we may have another question in there, Howard. We can finish up with that.
We have 3 more questions. So Sharon Thompson from Ireland says, thank you, wonderful presentation. How can organizations plan for including people with lived experience of palliative care and children's palliative care in their advocacy for universal health coverage? How can advocates best help?
Elena, I think that's yours.
Yeah, well, thank you, Sharon, and nice to know that you're here. Sharon's a wonderful advocate for palliative care. I think one of the absolutely key things I would argue passionately, that we should include people with lived experience as advocates, because they have a very unique expertise. And I think how we can include them is a question that we're still answering. Indeed, Stephen and I had a long call on this yesterday on this very topic, discussing with the NCD Alliance how we can best get the views and voices of people with palliative care expressed as part of our advocacy program. And I think that really it's by having meaningful engagement with them at every point in the programs. So in policy making, in I mean, for example, the WHPCA has lived experience trustees on the board. I'm a lived experience person as the advocacy officer. So having people with lived experience involved in meaningful roles and valuing their expertise alongside technical expertise of individuals who come with different expertise, say educational expertise or drug expertise or expertise of palliative care. I think it's something which the WHO has helped us with their recent framework on meaningful engagement of people with NCDs. And I'd recommend you have a look at that document, which is a lot of the document is transferable to palliative care. And I think it's a very valuable document. I could go on for a long time about this, so I better be quiet. But
thank you very much. Yeah, it's really important to reach out, and we have been guilty in the past of being whether you want to call it paternalistic or maternalistic in terms of protecting our patients from having to speak publicly about palliative care. But many of them want to, not everyone, but many do, and we shouldn't. We should take advantage of that opportunity, that meaningful opportunity for people with lived experience. Let's try to get one more question in if we can.
Okay, so we have Laura Dale Harris from Global Trials Foundation. Thank you all for such a great presentation. One question: has the unmet need for palliative care, that's adults, children, or both, been costed, either at a national or international level? What will it take to provide palliative care to all?
Laura, a very good question. Thank you for that question. We haven't really answered that question, but I think it's a question we could attempt to answer and do projections. We know how to do. We have a costing model that we published that was developed in Romania that anyone can use to cost palliative care in their country or even their region. We also have, I think the more important question is that cost an added cost to the healthcare system, or is it a substitute cost for other care? And that's a very tricky question. We have lots of evidence that palliative care is cost effective, that it reduces unnecessary hospitalization and non-beneficial treatment, and that patients are more or less likely to, we prevent hospitalizations and trips to the emergency room and things like that. But measuring that in a global context is quite difficult. So it really is a question of cost effectiveness of palliative care, and we'll take that suggestion forward and see if we can cost it. But we also need to look at the savings part. I'm afraid I think we're out of time now for questions, folks. We're going to be wrapping up. We do thank you all for coming. I want to mention that next year is the 10th anniversary of the passage of the World Health Assembly's resolution on palliative care, and we're looking forward to some special activities with WHO to both to honor that fact that the resolution was passed, but to also measure how much progress or lack thereof there is in palliative care development in the 10 years. So on that note, I guess we'll wish you all the very best. Stay well, do good work, and keep in touch. Thanks, everyone. And thanks everyone.
Thanks, everyone.
Bye for now.